रिकॉर्डिंग चालू कर. So good afternoon, everyone. I am Dr. Abhijeet Khandelwal, professor in Department of TB and Chest, Indus Medical College Hospital and Research Center, Indore. Today, what we are going to discuss is regarding the issue of the influenza in adult and the comorbid condition. What as we all know, today now the season of the influenza is going on, and a lot of the patients we are getting with the seasonal cough and cold view, and now we are getting the H1N1 also. So the topic of today is very interesting and very important. So I am going to discuss in the influenza in adult and the comorbid conditions. So the content which I am going to discuss is what is influenza outbreak, pandemic, impact of influenza vaccine safety and effectiveness, when, whom, and how to vaccinate. So to introduce it's a epidemic described by the Hippocrates in the 5th century BC. Respiratory disease, from the Italian word, it's a the influenza. 1933, the discovery of the influenza virus and the first description of the influenza epidemic in Europe in 1173 to 74. So it said the influenza virus have the several subtypes. It's basically the orthomyxi, the viron family, and having the A, B, C, three subtypes. A having the 18 HA protein and the 11 9A protein, the H1, H2, N1, N2, which having a lot of the combination like H1N1, H1N2, H2N1, H2N2. A and B cause the seasonal epidemic. C mainly causes the mild respiratory illness. Influenza A is divided into the subtype based on the HA or NA protein. HA and NA gene can be resorted between the strains, generating novel subtype. Different influenza A subtype result from the different combination of HA and the NA proteins. So the influenza infection has a variety of symptoms. Clinical symptom influenza infections are asymptomatic in 30 to 50% of the cases. And commonly symptoms include the abrupt onset of fever near about 38 to 40 degrees Celsius, sore throat, unproductive cough, runny and stuffy nose, headache, myalgia, chills, anorexia, and extreme fatigue. Uncommon symptoms include the photophobia, abdominal pain, and diarrhea. Illness improve in under 7 days. Cough and malaise may persist for a week. Children may experience the high fever, then can lead to the febrile seizure. Fever may absent in elderly. Presenting sign may be the only anorexia, lassitude, and the confusion. The virus shedding in adult from the day before symptoms appear until the 5 days after the illness onset. Young children several days before illness onset until the more than 10 days afterward. Severely immunocompromised patient weeks to months. The symptoms associated with the seasonal influenza are well defined and can vary between the individual. You can go, because it's a busy slide, you can go if you lost any topic, you can any words, you can go around that. So on the next, the clinical differentiation between the common cold and flu. More common in influenza than common cold is the high fever for lasting 3 to 4 days, headache, myalgia, fatigue, weakness, extreme exhaustion, severe chest discomfort, and cough. More common in cold than influenza is stuffy nose is common, sneezing is common, cough is generally mild to moderate. Symptoms such as the fever, headache, ache and pain, and exhaustion are rare, those with cold. So the influenza virus are spread by the virus-laden aerosol. How influenza virus are spread from person to person, primarily through the transmission. Require close source and the recipient, as the droplets only travel less than 1 m. By contact with surface contaminated with respiratory aerosol by airborne transmission to evaporate droplet period of time. Data are limited. Virus transmission may be slow by the social distancing. The source is the CDC of all the slides. Okay. Next, the influenza pandemic and the emerging new pending threat exists since 1900 century. So the first in the 1918 is Spanish flu, then the 1957 Asian flu S2N1, into 1968 the Hong Kong flu, then the in Russia, then again in the Hong Kong, then again in the Hong Kong, then Dutch, then global, until 2003 it's global. And in the 1918 Spanish flu, there are more than 50 million deaths. The circulation of the H5N1 in the poultry and the highly fatality rate has raised concern over the H5N1 pandemic. If this virus acquire the capacity for sustained human-to-human transmission dynamic are described using the reproductive number and the case fatality ratio, which may vary depending on the country and the season. The emergence of the H1N1 has demonstrated the difficulty in the predicting pandemic. So this all the years in the India, the season influenza number under cases and death from 2010 to 20. In 2010, there is the confirmed case of the 20,606 and the death was the 1763. And 2020 till on the September 20730 and the death was the 24. Highest seen in the 2015, the 42,000 cases and death is near about 3,000. So the recently the lab confirmed in Indian influ data, lab-based real-world evidence insights. These are retrospective lab data from across diagnostic lab and hospital across the select states. Sample population of the 12,825, mean age was 35.9 years. Standard deviation is 23.9. Range from the 8 months to 100 years. Males was the 51%. Time interval is the April 2014 to December 2017. State-wise sample mix in Maharashtra, Delhi, Tamil Nadu, UP, Haryana, Rajasthan, and the maximum sample were taken from the Maharashtra. In Delhi, the 17.1%, Haryana 2.4%, Uttar Pradesh 4.4%, Rajasthan 0.3%, and Maharashtra 67.7%, and the Tamil Nadu 9.1%. So the percentage distribution of the total burden by the age category, if you see, then you can see that most of the patient are age between 30 to 50 year of adult, showing the highest among the 1/3 contribution of the H1N1, more than 76%, 0 to 3 9%, 3 to 5 6%, 5 to 18 10%, 18 to 30 40%, 50 to 60 14%. So at the 60 to 79%. This is the influenza burden of disease is greater in the lower to middle income country than in the high income country. A study performed by the Global Burden of Disease 2017 Influenza Collaboration estimated that the influenza attributed burden to the LRTI for every country globally in 2017. Influenza LRTI incidences and hospitalization were typically higher to low to middle income countries than in the higher income country. You can see the Australia, USA, France, Germany, UK. And India stood in 8th number. So the influenza disease and influenza-like illness. For a doctor, it's not easy to conclude if the case of the ILI is caused by the influenza virus, because numerous other viruses and bacteria infecting the respiratory tract causes the similar symptom. A simple correlation between the clinical appearance and infective microorganism does not exist in respiratory disease. Only microbiological laboratory can determine which microorganism called the influenza-like illness. So the influenza having the lot of the complication also, like the bacterial pneumonia, if it getting the severe, the ear infection, especially the otitis media, the sinus infection in the form of the sinusitis, worsening of the chronic medical conditions such as the congestive heart failure, asthma or diabetes. Sometimes the patient came with the viral infection with exacerbation of the COPD, and the asthma, sometimes they present with the cardiac failure. So the issue is that who recommend annual vaccination, especially the pregnant woman at the any stage of pregnancy, children between 6 months to 5 years, elderly individual with chronic medical condition, healthcare workers. But as per the recent WHO slogan, don't wait, just vaccinate. So I think every age group should be take the prophylactic vaccination in the month of July to August in India, because we belong to the southern hemisphere. So the during the COVID-19 pandemic, WHO recommend the seasonal influenza vaccination for highest priority to the all health worker and older adult, priority if no particular order, pregnant women, individual with a specific chronic medical condition, children of 6 to near about 60 months of age. It means up to the 5 years. So the influenza and the healthcare worker, if you see the burden, the healthcare workers are additional risk of being exposed to the influenza compared to the general population. There is passing of influenza to patients who are increased risk of the severe disease and may respond less well to the vaccine. Transmission of the influenza from the healthcare workers to patient was given as a principal source of infection for patient in the review of the nosocomial influenza infection. Large staff absence due to the influenza can impact and disrupt the health services. Vaccination rates of the healthcare worker remain low in many countries. A review of the healthcare worker attitude to influenza vaccination found lack of the knowledge and lack of the convenient access to the vaccine as the main reason for lack of the vaccine uptake. The benefit of the vaccination is not only protect the healthcare worker and it also protect the vulnerable patient, and it's our moral duty to protect our patients from if we take the vaccination. It also may reduce the work of the assistance and the consequent disruption to the health services. Economic benefit, the vaccination of the healthcare worker has economic benefit. A Thai study found to the cost of the investigating an influenza outbreak in their intensive care ward was over the 10 times to that of the vaccination of all of the staff. Another study found that the economic benefit outweighed the cost by the factor of 4.5. Burden study indicate that the nearly all the influenza vaccination recommendation target older adults who are generally over 65 but can range from the low as 50. The elderly are known to suffer more frequently from the serious morbidity and mortality due to influenza. It is suggested that the low and the middle income country may have the higher mortality than in the higher income country. People aged more than the 85-year-old were 16 times more likely to die from an influenza-related illness compared with the person aged 65 to 69 years. What are the benefit of the vaccinations? The influenza vaccination is known to reduce the severity of illness and complication. Influenza vaccination of the elderly not living in a care may reduce the number of the hospitalization by near about 40% and overall mortality by near about 57% during seasonal influenza. And among the nursing home, resident influenza vaccination can reduce the hospitalization all causes by 50% and risk of the pneumonia by about 60% and the risk of the death by 68%. It should be noted, however, the vaccine effectiveness decrease with age. Economical benefit, the cost saving and the vaccination of the elderly come from the reducing the hospitalization and death. Systemic reviews of the cost effectiveness analysis among the elderly population found influenza vaccine is deemed to be the cost effective or cost saving, especially the over 65 year of age. So if you go for the burden, this group include those with the cardiovascular, respiratory like asthma, chronic bronchitis, emphysema, and other pulmonary disease and metabolic disease such as the diabetes mellitus, renal dysfunction, immune suppressive condition, the chronic liver cases, especially with the cirrhosis, the neurodevelopment disorders, cerebral palsy, muscular dystrophy, cognitive disorder, morbid obesity, and hematological disease like sickle cell, thalassemia. The group are the higher risk from the serious influenza hospitalization and death. The elevated risk is driven by the age and the severity of the condition among the other factors. Especially these all are the literature for the influenza with patient with the chronic disease. So what are the benefit in case of the chronic diseases? The vaccination reduce death, severity, severe illness, complication, and hospitalization. Although immune compromised group do not respond too robustly to the vaccine as compared to the healthy individual. What are the economic benefits? Study looking for the economics of the influenza vaccination of those with the chronic disease indicate it is a cost effective. Example of these wide ranging study include the adult hemodialysis patient, asthma sufferers, and those with the cardiovascular diseases. Oh, what is the scenario in the pregnant women? Pregnant women are particular risk for the severe complication of death from the influenza, and at the risk is exacerbated by the comorbidities such as the asthma, diabetes mellitus, and obesity, and late trimester pregnancy. May also lead to the complications such as stillbirth, neonatal death, preterm delivery, and decreased birth weight. Maternal immunization against influenza not only protect the woman but also the prevent negative effect on the fetal development due to the maternal influenza infection and reduce the rate of the illness of the infant for at least the 6 months of the life. Inactivated vaccine has been shown to be safe and effective in pregnant women and their offspring when given to at any trimester. The other economic benefit, it has been found that the universal vaccination with inactivated influenza vaccine is cost saving relative to the providing supportive care alone in the pregnant population. And in addition to the Canada, the target vaccination of pregnant women with comorbidity has been found to be cost saving. So if we come to where the disease, the first is the influenza and the diabetes. The impact of the influenza in diabetes, all bacterial and viral infection, including the influenza, are associated with significant morbidity and mortality in a patient with diabetes, in a part because of the poor glycemic control and acidosis, as well as the comorbid condition, e.g. advanced age, renal diseases and cardiovascular diseases. The incidence of the diabetic ketoacidosis are associated with the hospital admission were noted to increase during the influenza epidemic years. The impact on the influenza and the diabetes in a population-based study, the risk of the hospitalization was found to be increased sixfold in the patient with diabetes compared with the age and the sex matched control subject. At risk, the patient, including those with the diabetes, are also at the increase the risk of the death from the influenza and secondary pneumonia. In a case control study, control subject matches for the age and the sex. The mortality risk due to the influenza was double in the diabetic patient and compared to the non-diabetic patient with the confidential ratio is 95 confidential interval. Estimated relative risk for the diabetes, the influenza epidemic occurred in the 1976 and 78. The estimated risk was calculated for the patient with the diabetic. We can see that the pneumonia and the death is more in compared to the normal patient as compared to diabetic patient, especially with the poor glycemic index. The diabetic acidosis and the coma in this figure, the number of the patient with diabetes who were hospitalized during the first 13 weeks of the 4 year of a study period is shown. The number of the hospitalization for ketoacidosis increased. In 1978 was week 5 to 9 in which influenza was epidemic. Although not specifically studies in the patient with diabetic, evidence suggested that the influenza can trigger acute myocardial infarction and increase coronary heart disease. The result taken the special significance for the patient with diabetic whose risk of the acute cardiovascular event as well as the short-term inpatient and long-term risk for the death following the acute myocardial infarction in the 2 to 4-fold higher than the patient without diabetes. Patient with diabetes may have the abnormality in the immune function and presume increased morbidity and mortality from the infection. Epidemiological studies support the fact that the patient with the diabetic, in particular those with the end organ complication of cardiac and the renal disease, are at the high risk for the complication, hospitalization, and death from the influenza and the pneumococcal disease. There is a sufficient evidence that the people are the diabetic generally have appropriate humoral immune response to the vaccination. The vaccination outcome in patient with diabetic, we can see that the after vaccination has been shown that to comparable between the patient with the diabetic and the healthy control subject in four case control study. Several research groups have documented the safety and the efficacy of the vaccination against the serious morbidity and the mortality of the influenza infection in patient with diabetic and in high risk patient, including those with the diabetics and for the cardiovascular disease in a subgroup analysis of the patient with diabetes. Recommendation for the influenza vaccination in the patient with diabetic and their close contact. All the patient with diabetic or more than 6 months of age, children less than 9-year age, patient who have never been vaccinated should receive the 2 influenza vaccine dose separately for at least for the 1 month. Close household contact for the people with diabetic, the healthcare worker providing the care of the people with diabetic, they should all take the vaccination. Need of the latest influenza vaccine. This is the WHO recommendation. With the change of the circulating influenza virus lead to the change of the influenza vaccine strain recommended annually for the both northern hemisphere and southern hemisphere to closely match the currently circulating the virus strain. As per the WHO, the most recent WHO influenza virus vaccine recommendation should be used independent of the hemisphere in the which country is situated. Normally, WHO in the month of the late May or the early June, they they release the strains for the vaccination, and the pharma companies made the vaccination as per their releasing strain, and then the vaccine came in the market as per the hemispheres. The Indian Academy of the Pediatrics that clearly shows that the guideline in the 2018-19 that the influenza vaccine should be offered about 2 weeks before the beginning of the flu season. One of the major change between the southern hemisphere and the northern hemisphere, H1N1 pandemic, the 09 like virus strain has been changed. These are the recommended composition of the influenza virus vaccine for the use of the 2021 southern hemisphere, and these are the vaccine for the use in the 2021-22 in the northern hemisphere. We can see that the Victoria 2570 was seen in the southern hemisphere, and here the from deleting the Hong Kong strain, now they are the Cambodia strain H3N2 like virus. You can go more thoroughly on any of the WHO site without the detail about the vaccination. So if you go for the influenza virus systematic, it has the spike virus having the hemagglutinin, neuroaminidase, ribonucleoprotein, M2 protein, M1 protein, and the lipid membrane. Hemagglutinin, surface protein that protrude from the membrane form spike, responsible for the attachment of the virus to the surface receptors to the epithelial cell by the hemagglutinin, and by the help of the neuraminidase, you can see that the surface protein that protrude from the membrane form spike responsible for the reduced viscosity of the mucus layer in the trachea, allowing the virus to pass through the reach to the epithelial cell. Release of the new virus particle from the infected cell. You can see that the virus composition, and then so as per the these they have changes the strain. So this is the type of the influenza vaccines in the available in the market. Uh, you can see the live attenuated and inactivated. Live attenuated contain the live virus that has been made the less harmful or harmless. And the second is the inactivated vaccine that contain the inactivated virus, and these have the three type: the whole virus, split viron, and subunit. Influvac is the third generation subunit vaccine, presented better tolerability and the lower reactogenicity as compared to the other vaccine. So if we can see this the flow chart, the living virus particle membrane protein, the hemagglutinin, and the neuroamidase, the lipid protein core with the active RNA. So the live vaccine attenuation, adaptation to the cold environment, temperature sensitive live attenuated vaccine, ultra centrifugation, inactivation, the whole virus vaccine. Now the organic solvent and the detergent, the split virus and the second generation year 1964, and the subunit is the 1976 of the third generation vaccine. So now we have the two, the split viral and the subunit vaccine. Subunit vaccine are less reactogenic with fewer adverse reaction, like Influvac Tetra is a subunit vaccine. The inactivated influenza antigen are available as the whole split, and the subunit vaccine, the whole virus vaccine, contain the intact virus particle, highest level of the reactogenicity and the adverse reaction. Split virus vaccine that contain the fragmented virus particle like the matrix protein as well as the surface antigen, fewer adverse reaction than the full virus vaccine. Subunit contain the mostly the surface antigen. Here you can get the split the viral protein as well as the surface antigen. But here, so the better tolerability and low reactogenetic than the any other vaccine. So subunit you get only the surface antigen, and the split you get the viral protein with surface antigen, and the whole you contain the whole intact virus particles. Why the subunit vaccine came into the existence? The hemaggglutinases and the neuroaminidase are the responsible for the attachment of the virus to the host cell. Only after this the viral replication takes place, and the nature response of the host immune system is to produce a specific anti-NA and anti-HA antibody and memory B cell specific to those HA and NA for future use, and therefore in the manufacturing process too, antibody titer against HA and NA are the marker for the immunogenicity of the vaccine, and there is no mention about any other part of the vaccine. So what is the role of the NA and HA specific antibody? They bind to the virus and neutralize it so that the attachment does not take place, and therefore the viral replication is prevented in the host. What is the role of the viral protein matrix protein? They take part in the viral replication, infection, and disease propagation. They have no role to play in the immunogenicity. Their presence in the vaccine lead to the local and the systemic reactogenicity. Low incidence of the reactogenicity with the subunit vaccine is the fault of the absence of the viral part, which is further established through the evidence. So as per these guidelines, the subunit vaccine having the less reactogenicity and the less side effect as compared to the split viral and the whole virus vaccine. So subunit vaccine are the similar immunogenicity as the split vaccine, but are the less reactogenic They have the immunoequivalent and associated with the lower frequency of the local and systemic reaction. You can see it in the chart and suggested the viral component has a more abundant in split and the whole virus than in compared to the subunit vaccine. Subunit vaccine are associated with significant fewer local adverse reaction than split virus. You can see the split virus was significantly independent predictor of the muscle pain and or swelling. In addition, use of the anti-fever pain medication was significantly lower with the subunit vaccine than any compared to the any another vaccine. Fever reaction is less frequent with the subunit vaccine than the uh, split virus vaccine. Fever occurs significantly more with the split and the whole virus vaccine as compared to the subunit vaccine. You can see the chart, the 2.4 and the 6.4 bar diagram. So there was a beautiful study which was published in by the Inder Neil Basu et al. And the immunogenicity and the safety of the two quadrivalent influenza vaccine in the healthy adult and the elderly participant in India. It's a phase 3 active control randomized trial, and they conclude that the subunit elicited in the adequate immune response with the favorable safety profile, which was compared with the reference vaccine. And the result is the pre and the post vaccination, the high titer for the both the vaccine was compared. The GMA verified from the 4.3 to 22.7 in the test, in the 3.7 to 21.6 in the reference vaccine of the group. The the seroprotective rate was 90% in the A strain and the range between the 43 to less than 60% for the B strain. And both the vaccine seroconversion varied with the 41 to 78%. How overall the reported adverse event for both vaccines is less than 1% comparable, reported local and the systemic. They have taken the from the March 2018 to April 2018 across the 12 sites of India. In this, the randomized observed blind study and the 480 participant was taking. So they also are receiving the single dose of the test vaccine, which is subunit, uh, and reference vaccine, which is the split viron, in the second group, in group B. And they found that the both having the equal but the less side effects. So in this, they were the same study. This is the division of the age group, the more than 18, 61, gender, male, female, comorbidities, at least one medical history finding the hypertension, diabetes, age-related issue, postmenopausal or menopausal. So finally, this is the chart for after the result. They found that the subunit vaccine is the immunoequivalent to the split viral vaccine across all the age group. There is one of the another study with the phase 3 randomized controlled trial of the immunogenicity and the safety of the quadrivalent versus the trivalent inactivated subunit vaccine in the adult and the elderly subjects, the both anti-hemoglobin and the virus neutralized antibody response. They are the 1980 subjects they have taken elderly across the 5 countries and are randomized to receive this vaccine. And they found that the TIV with the beta strain and TIV is a beta strain from the Victoria lineage and the Yamuna lineage. They found that the quadrivalent was non-inferior to immunogenicity to TIV with the match strain and superior to the alternate lineage beta strain of the TIV. Safety and tolerability both of the quadrivalent and the trivalent were comparable. So now the question is when to vaccinate. The global influenza surveillance and response therapy over the 106 member country, 136 NIC6, WHO, CSF4, ERLS and 11 H5 reference labs, Mumbai, Pune and Kasoli. And the seasonality of the flu vaccine is very important. India has distinct seasonality that might be related to the latitude and the environmental factor. Rainfall correlate with the influenza peaks in many of the cities. Recent surveillance data from the top tropical regions of the Asia have revealed a seasonal pattern characterized by the year-round low-level influenza virus circulation and peak occurring during the monsoon rainy season. The timing of the vaccine is the 2 week before the beginning of the season. Most recent WHO influenza vaccine recommended should be used independent of the hemisphere in which the country is situated. Was recognized is every area and where possible, then and the latest available vaccines are there. So this is the beautiful flow chart which is showing the increased vaccine access, vaccine only clinics you can plan, extended office hours, vaccines at all the visit places, and overcome practice-related barriers, the standing order, provider reminders, additional of the influenza vaccine to quality care checklist, increased demand, the consumer education by the stronger provider recommendation, by the using of the social media. Now we are using the final slogan is don't wait, just vaccinate yourself and your family beloved members. So these are the strategies by which we can increase the reach of the influenza vaccine to our country. So this is all about the influenza vaccine, especially the mentioning the difference between the subunit and the split variant. The subunit is good and the lesser side effect. And the second thing is you should take the vaccination whichever country you reside. That the 2 week before your flu season, that will give near about your 8 to 10 months of the protection. These are the different types of the vaccine available in market, and the influenza virus systematic issue that the spike, and nowadays the COVID is also there and the H1N1 are also there. I agree, these are not the swine flu vaccine, these are the seasonal influenza vaccine. So don't think that you are taking the anti, because the swine flu vaccines are the live vaccine and they're not very much easily available in the Indian market. So these are all the recommendations that you can give any of the patient of the more than 6 year, 6 months of age. Uh, and in the patient who are diabetic, they should be taken on the children at the 1 month of the apart age. So these are the serological protection compared between the vaccine. So this is all about you. If you have any question, you can raise your hand or the mention on the chat box. So I am very happy to give the answer. We will wait for 1 to 2 minutes. Otherwise, we will close this session. If you have any questions, you can raise your hand. So I think I am able to resolve all the queries. So Chahat, thank you for your support. And
Okay, sir.
okay, now we can close this session. And thank you very much to all who are listening. We have a two Zoom link session. One is for the speaker and the host, and second is for the audience.